Hello. So my talk today is on the future of long-acting antivirals for HIV prevention and treatment. These are my conflicts of interest. So why would we need long-acting antivirals? Remember, antiviral therapy in 2024 is so successful. One tablet per day, high genetic barrier, hardly discontinuations because of side effects. Why is there still a need for long-acting regimens? Well, in the case of prevention, it's easy. Oral PrEP has not worked equally well for all at-risk populations, and particularly women are not doing very well, and some of the trials have actually even failed to show protection with oral PrEP. It may also help to increase protection during sex acts, unwanted or simply being unexpected because of the long persistence of the drug level, ensure protection during alcohol or drug use, and adherence or stigma challenges may be addressed with long-acting agents, which will favor them over oral combinations. And then treatment fatigue plays a huge role in lifelong therapy. That may be very different with long actings. There clearly is a wish from patient side for treatment simplification, and in particular, they do not want to be reminded of HIV every day through the tablet intake. So let's focus on the future of long-acting ARV, first with prevention, then follow up with treatment. Now, the big news of 2024 is clearly the Purpose 1 trial, which was already released as a press release early on, but the full results were presented at the IS Munich meeting. And it was one of the very few meetings where actually people got up and gave the presenter, Linda Gelbecker, a standing ovation. And why was that so? Well, the Purpose 1 is a trial which looked at twice yearly subcutaneous lenacapavir injections with a capsid inhibitor versus daily oral tenofovir as PrEP in cisgender women. It was a 2-to-1 randomization, so either lenacapavir plus placebo or FTC TAF and placebo or FTC TDF placebo. And that was 2-to-1 randomization. It included cisgender women from South Africa or Uganda, which were aged between 16 and 25 and were very sexually active. The pre-specified interim analysis was done when 50% of participants completed more than 52 weeks, and that was done. And after that, because of the big striking difference in results, which I will show with you in a minute, the trial was stopped prematurely. So the overall follow-up, I think that's important to remember, is not that long. The primary analysis was lenacapavir versus background HIV incidence and FTC TAF versus background HIV incidence. Now, if you look at the baseline characteristics, you can see that this was a predominantly Black population. You can see very few were married. They were sexually very active, and you can see the high number of other concomitant sexually transmitted infections which were found, highlighting that this is absolutely the right population to study and use for a PrEP in need population. This slide summarizes the main results, and you can see that indeed there were 0 new incident HIV infections in the lenacapavir arm versus 2.02 incidents per 100 person years in the FTC TAF arm and 1.69 incidents in the FTC TDF arm, which related to 39 and 60 infections respectively. So clearly these 0 infections was sort of the big headline of the IS Munich meeting. I think it's important though to remember that people were screened by HIV RNA testing at screening. So that's how people with already existing HIV infection or potentially undergoing seroconversion were excluded. That led to the determination of the background HIV incidence, which was high with 2.41 per 100 person years. But then also note that at baseline, so when people were already randomized to receive their treatment, there was another RNA test. And already in that time frame between screening and baseline, there were another 7 individuals who then turned out to be HIV RNA positive. So they sort of got infected between screening and baseline. So there were 4 individuals with lenacapavir who correspondingly tested positive. These individuals were all put on ART immediately and did not enter the analysis. So it was a modified intent to treat. Remember that in some of the other trials with long-acting, particularly cabotegravir, these type of infections, so already seroconverting prior to exposure to the drug, were counted as infections, and that may explain some of the differences in the rate of infections between the different trials. Now, obviously, why do oral therapies work less well. Well, it's clearly all related to adherence. That was already seen in previous studies, confirmed in this study. You can see that the adherence to FDC-TAF and FDC-TDF really decreased over time. Low adherence, less than 2 doses per week, is in orange. You can see that really increases substantially and almost resembles everyone in the trial receiving oral therapy. And if you do a case sample versus matched control sample analysis, you can see that indeed, if you were really taking your oral PrEP, you were much more likely not to become infected. So again, there is this strong association between not taking tablets and being at increased risk of acquiring HIV infection. The lenacapavir treatment adherence, obviously, with a drug which stays there for half a year, was much, much better because of the few time points where you have to administer the drug only 2 times during the trial. And you can see that they were given on time in over 91% of cases. And so that, I think, is very reassuring. Looking at the injection site reactions, there were injection site reactions, but they seem to decrease over time, particularly with regard to nodule and pain. They seem to be improve a little bit over time. That's reassuring. Nevertheless, there were 4 injection site reactions which led to treatment discontinuation. So the question does remain, how is this going to play off in young individuals who may take this for 5, 10, 50, 20 years? So I think we will need more data in the long-term administration of this new strategy. Please also be aware that fortunately Purpose 1 is not the only trial with lenacapavir long-acting. There will be a whole range of other studies looking at other populations, including transgender women and men, as well as cisgender MSM. We will also have you as cisgender women, people who use drugs, and then also a more migrant-based population, which is important so that we gather information for different groups. A lot of the PrEP efforts have concentrated on MSM in Europe, and clearly there are other populations in need where we urgently need more data. Cabotegravir is also moving ahead with a new ultra-long formulation. PK data was shown at CROI earlier this year, which really showed a slower absorption and longer half-life than with the traditional 8-weekly intramuscular injection of cabotegravir. As you can see here in the dotted line, the black line is the traditional cabotegravir, and the other lines are much higher, reassuring us that there will be new formulations which will allow extended treatment durations or administration time points. If you look at the injection site reaction, I think it was interesting to see that they studied intramuscular as well as subcutaneously with this new ultra-long acting formulation. The subcutaneous formulation was tolerated less well because of erythema, nodule, and pain, which really occurred in everyone who participated in this trial. There were less injection site reactions in the intramuscular treated participants, and they were also very mild. So it looks as if intramuscular is the way forward for this new long-acting formulation. Then there's also a new oral formulation for PrEP as a follow-up drug for the islatravir, non-nucleoside reverse transcriptase translocation inhibitor, which led to lymphopenia, so that the program was stopped in prevention. This is a new chemically somewhat different compound, which also though shows long half-lives and has some potential for a once monthly oral administration. So we'll see more data around that. So it has entered phase 2. I think the big elephant in the room is who's going to pay for long-acting advances in prevention. So these drugs are more expensive to make than generic TDF FDC. But obviously, because of the striking difference in outcome, there is a strong push, and we'll have to see how that all works. Cabotegravir already has been approved by the European Medicines Agency, but again, there is a fierce period of price negotiations, so we'll have to see how that all works. But clearly, for individuals who want to use PrEP, this is a big advance, and hopefully this will be made accessible for everyone. Looking at the treatment aspects, I think it's important to highlight that there really is a whole range of long-acting agents in development for use in HIV treatment. That would be cabotegravir in the long-acting formulation, also a CAB prodrug, which may even be administered every 6 to 12 months, is under exploration. There are long-acting capsid inhibitors from ViiV, which are also undergoing investigation. Then there is the combination of lenacapavir with broad neutralizing antibodies, which promises one injection and one infusion every 6 months. And then there are a whole range of different oral therapies once weekly, including islatravir lenacapavir, which is just entering phase 3. Then we have the new integrase inhibitor from Gilead with a lenacapavir prodrug, promising once weekly formulation, once weekly oral NNRTI, and also a maturation inhibitor from ViiV. So quite a bit of backup substance in the pipeline. Some of the exciting trial results from this year are, among others, the first results of islatravir lenacapavir in people with HIV who were stable on BF-TAF with good CD4 counts and good lymphocyte counts without HBV, who were randomized either to the new once-weekly oral combination or continuing BF-TAF. And you can see that at week 26, the outcomes was just really striking, with over 94% in both arms being undetectable. So very good response rates, hardly anyone failing, and very little discontinuations because of side effects. So well tolerated and clearly a promising drug. The big question was obviously, is the currently lower islatravir dose studied going to have any impact on lymphopenia? That was not the case. Also, CD4 cell count was behaving similar between the BF-TAF arm and the islatravir lenacapavir arm. So that was very reassuring that the signal of lymphopenia was not seen, and that really gives us hope that this will make it through the phase 3 program as well. Lenacapavir plus broad-neutralizing antibodies has been studied in various populations. This was a study at CROI looking at individuals who were only susceptible to either TAB or ZAP, so only to one of the two broad-neutralizing antibodies. But if you use the higher dose of the one corresponding neutralizing antibodies, all patients maintain suppression for 6 months. So clearly showing this is a feasible approach. I think we still have some questions. Is this feasible to give an IV infusion every 6 months for, a large HIV clinic? I think there's some implementation issues, but it seems to work as a maintenance therapy. And so these are obviously also exciting data, and we'll see how these combinations further develop. The new INSTI from Gilead 1720, as well as the lenacapavir prodrug, both were presented at the International AIDS Conference, really showing very favorable PK profiles. The integrase inhibitor had a median half-life of 9.3 days, prodrug lenacapavir 11 days. Tolerance was very, very good. So this will be also put together as a combination and studied in a phase 2 and then eventually phase 3. And so we're all looking forward to see more data with this new once-weekly oral combination. So in summary, long-acting injectables clearly represent a new additional option for HIV prevention. And this is particularly true for individuals at substantial risk of HIV infection that may fill the gaps in PrEP uptake, adherence, and retention, and users who just simply don't get along with oral PrEP. So particularly women from Africa. More long-acting agents for HIV therapy intravenously, intramuscular, and subcutaneous are on their way, all showing very impressive PK results, promising 6-monthly treatment intervals. But then there is still a question of how expensive are they going to be. And then different once-weekly oral therapies are currently in phase 2 and some entering phase 3. And so there's a lot of exciting data to come, and hopefully we'll hear more at some of the upcoming conferences. And with that, I'll thank you and send you a friendly hello from the Bonn group. Thank you.